Brenton, from your perspective, so the oncology spend, you know, everybody puts that same slide up and shows what you spend on the surgery, the medicines, the hospital admissions, the ER visits, da 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 da. But I'd like you to go one layer deeper, and that is that I don't think anyone argues the fact that it's less expensive to treat cancer patients in the community setting in a private practice office than it is in a large hospital setting, even if it's an outpatient hospital setting. And it's not a subtle difference. But yet, everything, at least right now, has been aligned to be adverse to that model. And that's why more and more cancer doctors are giving up their practices and just signing up to be employed. Now, there may be a greater strategy there that you can reduce variance by then controlling that because it's fewer providers, because they're aggregating. But as you think about this question, also put it in the context of what do you think about this issue of site of service, not just an individual service type, but site of service?
Mm-hmm. Yeah, so I think what you're alluding to is a lot of 340B and other policies that make it more economically feasible to provide hospital-based versus community-based oncology care. And we have seen a tremendous shift in community oncology. It was 80–90% in 2004 happening in the community, and now it's about 50–50 due to a side effect largely of a lot of these policies. And I think as we go towards value-based care, it's going to be a really important point in terms of where can that totality of care happen. I think there are arguments for both sides in terms of large hospitals can have robust IT infrastructures and have connected specialists and subspecialists throughout and have a view into that. And alternatively, smaller practices are lean, they don't have as much bureaucracy, they can change their clinical processes on a dime and can therefore iterate a lot faster. And I think we've seen that with some of the 2014 ACO data. And so it'll be interesting to see as these two separate entities both shift to value-based care, how they're able to evolve. But certainly site of service has had an impact on the landscape of where oncology is being delivered today.
What do you think? I mean, there's been, I've actually witnessed it. There's a literal schizophrenia about the messaging from government. Now, this is CMS, and I know the people, and they really want to do the right thing. On the one hand, they want to incentivize patients to go to a site where quality's there, but it's the least expensive site of service. But on the other hand, same group of individuals that are putting out policies where, you know, you're cutting the revenue and the margin on drug, and that's in fact how oncologists make their living and support the oncology nurses and all the other added expenses. Mm-hmm. And inventory incredibly expensive drugs. Right. So what are your thoughts about that schizophrenia?
Sure. So I agree that policy, particularly among the government payers, has been a little schizophrenic. I think on one hand, there is this general understanding that bigger is better because we get scale. And with scale comes economies of production. And that should be true for all areas of medicine, just like it is for other aspects of the market. On the other hand, the more that we consolidate, the more providers have negotiating power to set rates or help set rates with commercial insurers, but also drive patients to certain types of care settings where the bills can be for exactly the same type of care can be double depending on the setting. So we've seen a number of studies that have shown that, particularly for drug-based cancer. So site of care concerns are an issue, they're real. At the same time, I would argue it's really good and healthy for cancer care and for patients to have a choice of where they get their care provided. It's good for families to be able to choose where they're going to get their care because there's transportation costs, there's other types of costs associated with the caring for one's loved one when they have cancer that are important for families to be able to choose. And also, choice brings competition, brings quality. So we're kind of struggling with those two sides of the market, if you will. I do think that there will be more consolidation coming as we transition to more incentives for reducing the costs of certain types of care or managing the costs of certain types of care. Smaller practices are just simply not going to be able to take that risk, or they're going to have to invest in things that they just don't have the money to or the access to capital to do. But I also think the incentives for the really strong incentives to drive patients into the hospital outpatient department are going to change dramatically once we have site of care service payments that normalize between the community and the hospital. MedPAC, which is the advisory committee for the Medicare program, has already recommended a 43% reduction in facility fees. That will dramatically change the incentives for patients being seen in a hospital setting as opposed to in the community setting.
Okay, great comments there. Now let's jump back over to Dr. Sagar and get her take.
Are there any challenges in working with community oncologists versus, hospital-based providers in this value-based world? We have actually worked with both community-based oncologists and facility-based groups as well. We have not seen a major change in how doctors approach this whole problem. The challenges may come in the infrastructure cost, but we've noticed that even hospitals find that this is a huge investment that they have to make in the EHR technology, or hiring somebody to look at their cost data, look at their claims data, and understand where they're not doing as well as someone else does compared to a national benchmark, for example. So the cost, the investment is pretty steep, I think, for hospitals as well. I don't think it can be downplayed. But overall, we've noticed that community oncologists are a little bit more open to the approach at this point. But I should say that we've been pleasantly surprised with a lot of facility-based practices as well. We've talked to several hospital-based groups. We have a couple of hospitals in our model as well. And they do have navigators in place. They do have very good survivorship programs in place that our model encourages. And they've done really well so far. But all these relationships are fairly new. So, like I said earlier, it's a test and learn process at this point. And as we go along, we'll understand the opportunity a little bit better.